I'm actually pretty bullish on AI. I think it actually is pretty good, and the best models are really good, and they are going to be, even now, they beat most board-certified human physicians in many, many things.
Hey everyone, welcome to Leadership Rounds, a podcast shining a spotlight on exceptional clinician executives thriving and driving innovation at the intersection of business and healthcare. I'm your host, Dr. Reena Pande, and together we'll explore the wisdom and insights of great healthcare executives and craft a prescription for leadership success, one candid conversation at a time.
So it is an absolute pleasure to have all of you guys here with us, and a super pleasure to have you with us, Zeke. You really don't need an introduction, but I will contentedly introduce you. So Zeke Emanuel is a physician, a bioethicist, leading thinker on healthcare policy. Was one of the folks who helped shape the Affordable Care Act, as many know, and has really spent decades working at the intersection of clinical care policy and system design, and it's an absolute pleasure. You've written several books on healthcare reform, and bioethics, but the newest one, Eat Your Ice Cream, a title which I'll candidly admit I kind of poo-pooed when I first saw it. It really takes a different turn, and so we're thrilled to have you here today to chat about that and all things, so welcome.
Thank you. All right. Good to be here.
For those of you who don't know me, let me just do a quickie intro. I introed you, but not myself. I'm Reena Pande. I'm a partner here at Oxyon, and I lead our clinician executive search practice. Former cardiologist, former academic cardiologist, and former chief medical officer myself of a virtual mental health company called Able2. So fun to be in this seat to interrogate you if I don't lose all my papers. Okay, let's see if the wind will cooperate with me. So I'm going to start at the end of the book. If I had four hands, I would be able to actually open up the book. Because I think the end of the book actually says a lot about why you wrote it. And you write, this is in the acknowledgement, so you have to make it all the way to the end to see this. At the end of 2023, I read one of the seemingly endless books being published by the wellness industrial complex. It infuriated me. And then you go on to say, the real thing that incensed me was the increasing tendency to make wellness into a kind of religion, to make it the end goal rather than just a means that fades into the background, while people pursue the valuable activities that make life meaningful. I love that. It's funny, you've been at the systems level for so long, but you dial down here into the individual level. Would just love your take on how you got to writing this book.
Well, one source is for any of the doctors in the room, people constantly coming up to you and asking you, how much should I drink? What diet should I be on, etc. And so this book is somehow, rather than do that ad infinitum, one place, go look at the book. And it has worked to some degree, on that. But it really was December 2023 when I had finished my last lecture at Wharton, and I got home, and Outlive was at my house, and I thought my brother sent it to me, and he swears he didn't, but I'll blame him anyway. And I read the book, and it just pissed me off for all sorts of reasons. One of which is, at one of his lines is, our only focus should be to outlive. And I'm like, that's wrong. That's clearly wrong. If any of you've read it, it's heavily focused on exercise, a little on diet, and a little on sleep. And it's like, first of all, just as a quantitative matter, that's just wrong in terms of wellness, that social relations are way more important. And he says literally nothing except in his two-page afterword about social relations. And so I thought, this is just all wrong. There are 6 things that go into wellness. And I sat down and in 3 weeks wrote 35,000 words, which was the first draft of this book. And the second draft was really just expanding some of the data and studies that I cited. And answering a few questions that people came up with, like, well, you talk about social relations. What about introverts who don't like to relate to people? How does what you recommend apply to them? By the way, it applies 100% to them. There are lots of studies out there. There's a guy, Nick Epley at Chicago, who's done a lot of the great studies where you ask introverts to act extroverted. They love it. They actually, happiness is up. They really enjoy interacting with people. It turns out everything you say about social relations apply to introverts as much as extroverts. Anyways, that was really the basis of the book. And I think, I think I've got the balance right. There are probably a few things I should have had in there that I don't have. People have asked me about pets. Red light therapy, which I have become a big fan of, actually. I don't do it yet, but I will. There's a recent review of it in Nature, 4-page review. If you haven't seen it, go look at it. It's very impressive and very persuasive. Maybe the most persuasive thing about it is there early studies by some Hungarians, but one of the spurs was early 1990s. They sent up some seeds to grow in zero gravity to try to figure out how plants were affected up in space. And they sent a red light up to give them light to grow. And the astronauts noticed that the scratches and cuts that they had on their hands when they were manipulating the plants under red light healed much more quickly with the red light therapy. And I'm like, that's a pretty cool story. And it lends a lot more credence, in my view, to the fact that there's something there. Anyway, we haven't had the good, proper RCTs, but there's something there.
When it's in the New England Journal and people...
No, it wasn't in the New England Journal. But here's my thing. I don't know if any of you work on long COVID or think about long COVID, but, there's a perfect place where people would love a therapy, and you could do an RCT like that in long COVID. And you know what the outcomes are going to be. Do they get more energy? Does a mental fog clear? I mean, there are lots of clear outcomes, but we haven't done it because, companies are going to make money by people like me, regardless of whether we can prove it works or not.
Yeah.
So the incentive structure just doesn't exist.
So here's a question for you. There's a tension that runs through the book, which is, as you're pointing out, we've gotten so focused on optimizing sleep and collecting data about our exercise and our diet and all this, that we've forgotten how to live.
Yeah.
How to live a meaningful life. Have we confused all the data and the means, with the actual end about how to live? And are we actually detracting from living well by being so intensely focused on the data?
Yeah. Well, first of all, I highly recommend getting rid of your Aura rings or whatever tracking stuff you're doing. Yes.
Everybody's covering.
Take it off now. I don't understand it. I'm not... I don't really track anything. I have had my VO2 max measured once, and that's enough for me. I don't figure out the obsession with it, and I think it does take a lot of mental space and a lot of energy that is really misplaced. So I'm very much against the excessive monitoring and quantification. The other thing is there is a theme that goes through the book that is related to the tension between narcissism and caring about other people. Because I think a big element in the wellness industrial complex is about me, and it's very narcissistic. And one of my big heroes is Benjamin Franklin. Far and away the most brilliant person ever to step foot north in all of the Americas. Maybe one of the most brilliant person, except Leonardo da Vinci, to ever live. I mean, he did everything, and he was world class in everything but his family life. I mean, really, he's an inventor, a scientist, a civic improver, a printer, a writer, a diplomat, a politician. You can go on. And he was in the top in everything he did. But one of his core beliefs was to be useful. That's what he tried to do. I will just tell you, he never patented one of his inventions. He's still in the top 5 of all-time inventors in history. And he never patented one of his inventions, even though he could. because his idea was, look, I inherited a lot of stuff from other people. I'm going to give the world this, and the world will, take it and improve it. And he didn't want to limit other people's ability to do that. And I think this idea of trying to be useful to the world, how are you going about trying to improve the condition of, your family, your community, your state, your country, the world, I think is a very motivating thing. And if you think about it, what gives, take people who have really meaningful lives. What gives their life meaning? It's typically not what they're doing for themselves. It's what they're doing for other people. So I think that's an important theme. And this sort of obsession about, spending more time getting myself perfect, or what I guess what the community calls optimizing, which I have no idea what that means. You can't even prove it, is nonsense.
So let's dig in here, because this theme of, so much of wellness is about self, as you're pointing out, and you've already pointed out the value of relationships, but I love that work that Robert Waldinger did in the Harvard Development Study that really, here the wellness industrial complex is so focused on me feeling better, but really the most valuable driver of better outcomes and lower mortality is others and relationships. So talk about how we weave that.
So the Harvard Adult Development Study was begun in the late 1930s and has been continuously going. It's still ongoing. And they enrolled sophomores. John F. Kennedy was enrolled as one of the original subjects. Ben Bradley, who was the legendary editor of the Washington Post during the Watergate era, was another one. And they combined that study with a study of more deprived inner city kids in Boston. And they were interested in trying to find out what are the things that predict for a good adult life. And they followed people now for over 85 years. It's pretty amazing. And uniformly, their conclusion is longevity, health, so the fewest disabilities, the fewest hospital admissions, and happiness were the biggest predictor were social interactions. How many close friends you have, how intense those friendships are, how many acquaintances you have. And if it were the only study, you'd say, well, small numbers, blah, 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 particular group, just the Bostonians. But that kind of research has been repeated multiple countries, Sweden, Australia, China, and over 3 million people in various different studies. One of my favorites is the Health and Retirement Study, which is a study that the U.S. government funds, tracks about 20,000 older Americans before retirement, after retirement, looks at their health, looks at their happiness and other factors that go in. And over an 8-year period, the people who had few friends and didn't spend a lot of time with friends compared to the people who had a number of close friends and spent time with them, the risk of mortality over 8 years, 25% less for the people who had a lot of friends. And there's been a growing body of research about what are the physiological differences that result from friendship. And it turns out it's, for one thing, the hypothalamus, pituitary, adrenal axis, and cortisol. And if you have friends, actually, you decrease your cortisol and stress hormones. You also release more oxytocin in your brain. But there are about 175 genes that get turned on when you're lonely, and they're heavily associated with inflammation, poor response to vaccines, poor response to viral infections, and more cardiovascular risk factors. So it's not just a psychological thing that your friends do. It's actually a biological thing that your friends do, and having more friends. The problem with our society is we're going in the wrong direction. It used to be, about 3 decades ago, only 6% of the population had 0 or 1 friends. Today, that's 19%. It used to be that about a quarter of meals were eaten alone. Now it's over 50% of meals are eaten alone. And Gen Z's the absolute worst. And that's partially they grew up on the phone, partially COVID. And they think, these social interactions are not going to be that satisfying. I'm not going to learn anything, etc. And uniformly, when you kind of, in experimental situations, force them to talk to people, just the reverse. They learn things, they enjoy the conversation, they're happier. And so we have to figure out how to get people more engaged.
So people may take away that deep friendship is the thing that matters, and deep friendships do matter.
Yes.
But you have a whole chapter in the book that's called Talk to Strangers.
Yeah.
And I gave a talk to high schools, my alma mater high school students once, and that was literally a slide in my slide deck, because these micro interactions that you have with other humans, like saying hello to your Uber driver or the barista who's pouring your coffee, also matter. Talk about that.
So I live in Washington, teach in Philadelphia, so I take the train a lot, and I talk a lot to the people who are sitting next to me or the conductor. But I was flying into Nashville this morning, and I asked the guy next to me, you live in Nashville or you coming to Nashville for work, right? Really simple question. No high stakes, right? No big deal, right? I live here. I said, so what do you do? Why were you in Washington, D.C.? Oh, well, I do construction, and I put in the concession stands at big sporting facilities and other kinds of facilities. And so we got on to talking a little bit about that. And then I said, what do you like about Nashville? He said, well, I grew up in California. I moved to Nashville, and I really like it because it's a slower pace. People are not so stuck up. And you go outside of the town, people are just much more friendly, just in the countryside right around Nashville, and you don't have to go that far. And he likes that pace, and he likes the friendliness that he says didn't happen or wasn't present in California. Those level of conversations, very empowering, but they're also, I think, they're such low stakes.
Totally.
That, what happens if, and this has happened to me plenty of times, you start talking to the person next to you and their mind is somewhere else. They're either thinking about the business or they're worried something bad has happened, and they've got monosyllabic responses. And immediately they're trying to get out of, all right, I can shut up and go back to my book and my computer and do whatever the hell I'm going to do. That's fine. But I'm not the worse off for that. Right? I haven't lost anything. And that was actually a message my dad was like the paradigmatic extrovert. He would talk to everybody and anybody. And, his message was just like, okay, they don't want to talk. What have you lost? Nothing.
Totally. Your dad and my dad are identical. Identical. I grew up with a dad who talked to every single person. It brought him joy.
Yeah.
To bring some joy to others. And so anyone who knows me knows I'm exactly the same, much to the chagrin of my children. I'm guessing your children also feel the same. Everybody.
You said something really important, and I just want to amplify it so it doesn't get lost for people. One of the important things about your starting a conversation with someone is not only is it good for you, it's also good for them. So you're being virtuous by talking to them because actually you're feeling better, but they're also feeling better. And maybe they're too shy to start. Maybe they are introverted and think it won't be that good. Whatever the reason is, you're actually beginning that conversation really, really is it's a virtuous act. And I don't think we think of initiating that conversation as something that you're doing good for someone else, but it really is a good thing that you're doing for other people.
My most recent one, which I'll just share, is that when I go to do groceries, you all should do this because it is so much fun. My daughter and I go, she's 18, she loves to go to the grocery store with me. I'm just taking it for as long as she'll do it with me. I ask her to predict how much the groceries will cost. And then we ask the person checking out the groceries to put a number on our groceries too. And it is the most fun that these people have all day long to play this game with us and see if they possibly won, which is so much fun. These little things.
And it costs you nothing.
Little things that brings so much joy to people's lives.
Yeah.
Before we leave the book, because I do want to zoom out to your other work, can we just talk about exercise? Because I just adore exercise. And my research as a cardiologist was in exercise and understanding the genetic and molecular signals that were correlated with the benefits that were coming from exercise. But I don't disagree at all with your sentence that exercise is a magical path to wellness and longevity. I do disagree with your point that golf is not exercise. And if anyone else agrees with me, please raise your hand. But let's just touch briefly on exercise before we zoom out.
Golf is a game. It's not exercise.
What if I walk the entire 18 holes, carrying my bag,
all right,
leaving away?
Let me just say the following, okay? First, every golfer I've talked to says, I carry my bags. But the facts are 70% of golfers in America take the cart.
Okay, I admit.
Maybe I only know the people who walk with their bag. Somehow, I doubt it, okay? Second, so if you take the cart, it's zero exercise, just zero.
This is true.
If you walk, you've now spent 4 hours walking for a few minutes of moderate exercise. It is not a exercise. It is a game. Perfectly fine. And then the real retort you should say to me is, well, it's very social. I said, fine. So count it in the social category, not the exercise category.
Fair.
All right. To exercise, you need to get your heart rate up and you need to get your breathing up, right, for the aerobic exercise. And, golf just doesn't do it last time. So you need 3 kinds of exercise. You need the aerobic to get your heart rate up and breathing. You need the strength training. And this is especially true for people who are sort of getting beyond 55 when the decline in muscle mass really accelerates, and you lose about 10% of your muscle mass every decade, unless you really work at it. And then you need balance and flexibility through yoga. That's the first point. You need all of them. And some exercise, gets you multiples of these. Obviously, something like swimming will get you both strength training and aerobic exercise. Bicycling, which I like to do, will get you the same, but only for the lower part of your body, not for the upper part of your body. The one that gets you everything is cross-country skiing. And it is interesting, parenthetically. If I don't know how many of you are into your VO2 max, but VO2 max is probably the best measure of your physical health.
Aerobic capacity.
Yeah, aerobic capacity. And I guess there's one person now over 100, but mostly 90s are like, and there aren't that many people over the 90s. You can Google the best VO2 maxes in the world. Turns out that almost all of the top people in the 90s are either Norwegian cross-country skiers or bicyclists. My nephew was very, very, he's a big runner, very pissed off that there were no runners in the top group of VO2 maxes. I don't know why that is. Anyway, what was I talking about? Okay.
You're good. Keep going.
So there's a limit to how much benefit you get from exercise. And I think one of the things that did piss me off about Peter Attia's book is he wants people to do 10 hours a week of exercise. It turns out that there's diminishing marginal return, no surprise to any of you, right? You go up, and the CDC recommends 75 minutes of vigorous, 150 of moderate, and the peak is probably around 150 of vigorous and 300 of moderate. And then it really plateaus. You get very, very little benefit for more and more time. But you do run the risk of more injury the more you exercise, and that's sort of inevitable. And the older you get, the slower your recovery from any injury is going to be. So don't do more than is going to be optimal for you, because you're just risking injuring yourself and then setting yourself back. And I think this is something that a lot of the wellness industrial complex influencers do not understand and have ignored.
Yeah. So let's leave the book to the side for a second, or not for a second, for the rest of the conversation. Because here we are zoomed in on the individual, but you've really spent your career focused on systems and impact at scale.
Yeah.
So would love to step into the bigger view and the bigger lens of what you're seeing in the healthcare ecosystem these days. I couldn't get out of this conversation without the letters A and I. So I know we've spoken a little bit about what your perspective on AI and where you think it's working and where you think it's problematic, and give us your perspective from a now broader lens of the change.
So I'm actually pretty bullish on AI. I think it actually is pretty good, and the best models are really good, and they are going to be even now they beat most board certified human physicians in many things. So we've recently we just submitted a paper that looked at accruing information from patients, creating a differential diagnosis, then ordering tests to establish a definitive diagnosis, managing patients with chronic illness, and what was the last one we did? I don't know what, it'll come to me. Empathy, very important. And in each one of those categories, AI is either as good as a human or human AI hybrids or better, and not all consistently in every category, but we're going there. And the AI is only improving very rapidly, and humans aren't moving. We're the same we were 50 years ago. So that makes me very bullish. That's the first thing. The second thing is, if you look at the history of AI in other areas, and I think the one that is best documented is chess. So in 2005, Garry Kasparov was beaten by DeepMind. And for the next 12 years, there was sort of competition in winning, flip back and forth between AI, human hybrids, and grandmasters. And then in 2017, AI definitively beat humans, and no human or human AI hybrid has come close to AI winning. And what is interesting is, as AI gets better and better, human AI hybrids actually get worse and worse and worse. And this is a very important finding, which I think most people don't appreciate. Why is that? Because humans, quote unquote, correct AI, but in fact are more frequently, as AI gets better, actually introducing error, not introducing corrections. And this has very important consequences for when we roll out AI into the clinic. And we want humans in the loop. The phrase every medical society, both in the U.S. and globally, I mean, look at the British Medical Association, all sorts of associations, all say the same thing. Human will be in the loop. Human will have the final check, blah, blah, blah. AMA has it. ACP has it. The American Academy of Family Medicine. Bob Wachter in his book. But that's actually not going to be the best medicine. That's going to be bad, because they're going to be introducing more errors than when AI really is definitively won. So I think that's where we're going, and that's one of the things that makes me bullish. The second thing that makes me very bullish is probably the place our healthcare system sucks the most is in managing chronic illness, hypertension, diabetes. And here I think AI is going to have just a huge advantage compared to human doctors. They can check in once, twice, 3 times a day. They can follow guidelines way better than we follow guidelines. I just think it's going to be way better for that community. I'm really excited about the CMS's access model, because I think it may well be able to give us some really definitive examples of how that works in the real world.
On the chronic disease point, can you share the data you were sharing earlier about the Stanford study?
So I'm overweighting this study, so let me just put the disclaimer in.
An N of 16 per arm is not a huge study, however.
It's a randomized controlled trial of 16 in each arm, so 32 total patients, done by some Stanford medical students. And in one arm, autonomous AI managing new diabetic patients to get to the right insulin dose for stable glucose. Autonomous, no clinician involved. They followed a guideline and told the patient how to adjust their insulin. On the flip side was regular PCP with Alexa sent to the patient at home, and the Alexa reminded the patient to measure their glucose and take their insulin twice a day. And the outcome measure was how long it took to get to a stable insulin dose. So on the autonomous AI, how long did it take?
Anyone have a guess?
What? 45 days. Any others? 2 weeks.
45 days, 2 weeks.
Come on. Huh? 7 days. 7 days too short. It was 15 days. All right? Primary care doc.
I guess, too.
Who said that? That's 12 weeks? Okay. Others? They cut the study at 8 weeks, and they still hadn't gotten there. 56 days, still hadn't gotten there. Very important. Now, tiny study, one disease, blah, blah, blah. And only looking at one aspect of that disease. It didn't talk about the hypercholesterolemia, the hypertension, et cetera. But that's the kind of power I think we're likely to get from AI that we just cannot get from our usual human clinical teams. And so that's really the kind of stuff that makes me excited. We need big studies, and we need to look at other diseases, chronic illnesses. But if we got 80-90% of diabetics under control, and we got 80-90% of hypertensives under control, first of all, we'd have a lot fewer people admitted to the hospital, and we'd save a whole ton of money. And patients would be better off because they'd have fewer strokes, fewer amputations, fewer chronic renal failure problems, etc. So that is the kind of thing that really excites me about AI.
Yeah, I love that. I'm going to just ask a few more questions, and we'll open it up to you guys to ask your questions of Zeke. But it strikes me that as technology is advancing so fast forward, we may need a different breed of clinicians. And I spend a lot of my time thinking about clinician executives in particular, and how we can have a voice and drive value in building and growing all this innovation in healthcare. You've certainly contributed on the policy and systems reform side. How do you think about how we grow the next cadre of clinicians? You've spoken a lot about medical education reform, and I know it's a hot button item for you, but how do you think about the clinician voice in driving change broadly, and how do we train differently the next generation of clinicians?
Well, let me just talk about the next generation vis-a-vis AI. And here I think we have to be really careful and nimble, because I think it's easy to get things wrong because it is changing so fast. So I just want to rewind like 10 years. And 10 years ago, maybe 15 years ago, everyone's talking about, wow, computer science is going to be the key. Everyone's going to have to know how to program. That's going to be critical. And here we are, 2026, there's vibe coding, and no one has to know how to program. It's a total wasted skill. And so I worry about we're going to train doctors for a wasted skill if we train them for AI. So I think we're going to have to be pretty nimble and recognize that we're likely to make a lot of mistakes in this process, and work, educate the students to be alert to how things are changing and how they might have to educate themselves along the way. So I think that's really important. I do think on the other side, it's also very, very important that we get doctors better communication skills. Tests of docs versus AI on the empathy score, we don't come out well. Now, I should caveat this, as Al Haig would have said. It's not been tested with real patients, but tested with patient actors. It is about to be tested with real patients. But Google has this thing called Amy, which is their AI doc. And with patient actors, Amy is much more empathetic, scored by the patient actors, much more empathetic than real doctors. Why is that? Well, we know that you can tune AI to be encouraging and reassuring to people, right? One of the things AI does that we as doctors are terrible at is repeat back to a patient what they've heard. Now, I've heard from you. We don't do that, you know. Similarly, we're just not as kind, I think, as AI happens to be. And I think training doctors on this kind of better communication. Now it's happening. Someone reported to me recently that they went to a newly minted doctor and really good, but it seemed a little formulaic as opposed to much more spontaneous and natural and organic, and therefore sort of put him off rather than made him feel comfortable. But I think that's a very important skill set that we have to develop.
Well, we don't need to be human computers anymore, and frankly can't be, because there's way too much information, right? We have our friend from Open Evidence here, right? It's there are other ways for us to get the knowledge, but I would have thought we would have had more points on empathy, and that would be the place where we would still value it.
Lots of people make that prediction. When I ask them, who wins, lots of people make the prediction that that's the area where we're better. And I would say, I don't know how many of you have looked at Bob Wachner's book called The Giant Leap about AI. And he goes on and, that we can console and we can comfort and lots of things that we're supposed to be able to do with people. I don't know.
Maybe not.
Yeah.
I can keep asking you questions all night, but I want to give an opportunity to our friends here in the audience. Casey's got a microphone. If, Miriam's got a question. And just, I know you, but introduce yourself so that the rest of the group knows who you are.
I am Miriam Paramore. I'm the founder and CEO of a consumer drug pricing affordability tool called RX Utility. So thank you. I wanted to tell you that I threw out my Ultra Human ring, which is a competitor to Aura, as soon as I got to that part of your book. I actually heard that in an interview.
Wow.
And I had already put it on my shelf because I was sick of looking at it since my insomnia hadn't changed. I was just looking at data of how bad my insomnia was. But I loved what you said. I just get up in the morning and decide if I feel good or not. That's how I know if I slept well. I was like, okay, well, that's pretty good. But what I wanted to ask about, I wanted to say one thing about empathy. A friend of mine had surgery last week to remove a tumor for melanoma that had reoccurred. Wow. And I was in the hospital with her here in town with her partner. And after the surgery was over, it took a little longer. The surgeon consult after was a text message that said, things were okay. You'll have a follow-up with your oncologist next week. So I would take any
great empathy. Great empathy.
Computer over that text message. But my real question is, on your book, do you have anything to say about the intersection of your findings with the blue zone stuff, the Ikigai and the villages, et cetera? Thank you.
So I don't know nothing about villages. I do know something about the blue zones. And we should be clear, there's some controversy about the blue zones. There's been a lot of criticism of the blue zones, saying that the people who are in the blue zones have more or less manufactured their birthdays. They claim to live longer, and therefore there's no real data. And, if you look at Okinawa, they really don't have they're not longer lived. I think that's mostly nonsense. First of all, that paper has never been accepted in the peer-reviewed journal. Now, I don't want to say that peer review is the only gold standard, but I do want to say that the original finding of a blue zone was done with an epidemiologist from Belgium who everyone in the world believes is like the most rigorous guy in epidemiology and demography. And he went not only to the birth records, but to the church baptismal, I think it was in Sardinia, baptismal. And everyone believes that at least that blue zone, very, very rigorously established. And the same methods, as I understand it, have been used in all the other blue zones. Almost all of the recommendations that I have. Now, people in the blue zones tend not to exercise. They walk a lot, but everything else is pretty similar. in terms of what they eat, the socialization, and living in a community. And they walk as opposed to set aside time to exercise. So I think they're onto something. I think there's a lot there. So I'm a big believer, and I have looked, as I said, looked at the criticisms a lot, and I don't think they're really substantial and undercut the validity of that original research.
Hi, my name is Maki. I work for a health tech startup called Thrive Mobile. And in full transparency, my husband is an anesthesiologist at Vanderbilt. He trained there, did residency there. He was part of the first interprofessional program cohort at Vanderbilt Medical School with the nursing school and the pharmacy school. He now leads that on faculty. We have medical students at our house a lot. And so I see medical students coming up through medical school. I'm not surprised that AI is more empathetic when he does 40, 60 cases a day in the outpatient GI setting. It's kind of alarming that he's doing anesthesia for 40 patients. But all that being said, I'm curious as to how you think about AI in the context of interdisciplinary care teams and like the role of the physician as we have nurses and CHWs and community health workers and social workers who are taking on so much important work in the healthcare system, both in terms of healthcare needs clinically from a BH standpoint and social care, and how you think about what a physician role looks like, not only in the context of AI and clinical practice, but overseeing teams of different types of providers.
So if you take AI out of that, I think the multidisciplinary team is, especially for people with chronic illness and multiple chronic illnesses, absolutely essential. I don't see how you can properly manage those people without a multidisciplinary team. I mean, you have to have a pharmacist, you have to have a care coordinator, and for many of these patients, especially who rely on social services, you have to have a social worker involved. So I think that now whether AI can take over some of those functions, will depend upon how digital some of those functions can be. But I think almost invariably there's going to be some of that. And I think AI, just to give you an example, there are lots of combinations of drugs we shouldn't have, and certainly combinations we shouldn't administer to older patients. And I think AI is likely to do a much better job than humans, even well-skilled human pharmacists, in assessing those drug-drug interactions, identifying patients who are at high risk for problems than the humans can. So I think AI will be integrated into those kind of teams, and maybe even replace people. I will say, parenthetically, one of the things I've been trying to get CMS to reimburse for and to mandate is annual deprescribing for patients. There's a human tendency to add and not to subtract. One of the best papers, there's a paper in 2021 in Nature that gave people a bunch of problems to solve, where you could easily solve them by subtracting and more complicated to solve them by adding things. Overwhelmingly, people approach a problem and they add, they don't take away to solve a problem. And I think we do the same thing with medicine, right? Add another medicine, and we don't take away ones that should be taken away. So I actually think this is one case of where deprescribing, especially for patients who are on more than a few medicines, is probably really, really important, especially as they get older. Too many medication interactions, too many medications that are no longer doing any good. Anyway,
yeah,
I'm not running up a brick wall, just that no one has thought it important enough to put at the top of the agenda. But I think we could save a lot of money that way.
Interesting.
Anyway.
Thanks. Hi, I'm Jeremy. I lead the commercial teams with a company called TimeDoc Health. We're a virtual chronic care management, remote patient monitoring company. You mentioned the access model earlier and being bullish on that. And I understand some of the sentiment, but at the same time, there's a lot of sort of mixed opinions on how that's going to work. And I'm really curious as we think about AI and really sort of low reimbursement rates associated with the access model, what you think it's going to take in order for there to be broader adoption of that model, because there's going to be a lot of cost involved for provider groups and other organizations to be able to stand up and support patients in that value-based care model that may not have the AI infrastructure already to be able to support it.
So we've got a problem with AI. You can't pay fee for service for AI. It just won't work because the bill will run up and you won't get much bang for the bill because people will prescribe it to everyone and won't follow up, etc. So you do have to have some other value-based payment model for adopting AI. I like the fact that they're trying to pay on outcomes, and I think that's a good thing. Now, whether they need to pay some startup fee or not, I think is, we're going to learn a little bit about it. At the moment, there hasn't been a problem of enough interest. There seems to be enough interest. I just 10 days ago talked to Jacob about it. So I'm not as skeptical as you are that now it may be that docs try to implement it and realize they need to invest much more money to get the infrastructure working, to get themselves up to skill, whoever in the office, the patients, etc. And that, you may be right about that. I think they're pretty committed to it, so I think they will quickly pivot to figure that out. I could be wrong, but that's the way I would think of, they have a long history of deploying models where they do provide an upfront startup cost, especially for rural areas where people don't have a lot of cash. So they probably would go that direction. That would be my suspicion.
I'm sure there's lots of other questions.
One other question. Yeah.
We'll take one more.
One more. No pressure. I'm trying to marry a few of your comments. So one of them about where computer science is today, then the one about what that might mean for medicine in 10 years, and then juxtapose that with the starting comments we had about that need for social interaction. I'm sorry, I didn't introduce myself. I'm Melinda Henderson. I'm an internist and geriatrician. And when I do clinical care here in Nashville, I see so much of what I bring to patients is that human interaction. I do home visits. And so, that is, I want to see where you think that's going to be. What is it going to be to be a doctor in 10 years if the science part is all figured out?
If the science part is
all figured out through AI,
Oh, I do think it'll be more human interaction. I think I don't know that we would need doctors for the consoling or part. That doesn't mean it wouldn't benefit for other reasons between people. So the idea that you won't need 3 years of medical school or 4 years of medical school, 3 years of internship and residency to do the consoling part. But that may be the most beneficial thing you can do, as well as, understand what is supposed to be done in this case just because you consulted AI. So I think we don't know exactly how the whole picture is going to fit together going forward. But I do think it turns out that's not a medical skill so much as a human skill. And again, this is where many years ago, probably maybe not quite a decade, but something close to a decade, 8 years ago, I wrote an article about, are we overemphasizing IQ and underemphasizing EQ in admitting our students to medicine? I think that's one of our biggest problems. Of course, you need a certain, level of IQ. But beyond that, it's not more IQ is going to make you a better doctor. It's more EQ that's going to make you a better doctor. And we do almost nothing when we screen patients, when we interview patients. I mean, prospective medical students or prospective interns, to actually look at their EQ. But I think that's going to be a much more important element than the IQ component of what we place so much emphasis on. And by the way, it's not just us. You go to Europe and, everything about it being admitted to a medical curriculum, there's one test typically, and that's all about, how much knowledge you have, and they have no screening. I mean, we at least interview people. They don't even do that.
On that note, that we need to more EQ in addition to IQ, which is a great finishing thought here. Thank you so much for spending this evening with us. For those of you who can stay around, Zeke has offered to do a book signing on the other side of the space, so feel free to make your way over to the other side as soon as we're done here. I spent a lot of my time thinking about clinician executives, and I think you're sort of a consummate example of having been
Never been one.
Clinician and a leader and a voice, and irreverent in the best ways, I would say, and making your voice heard. Let me ask this one last question in closing, which is, if every person in this room changed one behavior walking out of the space, which behavior would you recommend that would have the biggest impact?
I don't know your situation, so I'm gonna shoot this to a modal person. I'm a big believer in what I like to call wellness trifectas. What is the one thing you can do that involve multiple wellness activities, because they sort of all augment each other? And I'm a big believer that the optimal one is having dinner parties, because you cook and really good food. You have friends over and socialize and keep your mind sharp. If I had to make a recommendation, and again, I have no idea how you're leading your lives, but we do a lot of dinner parties and invite a lot of people. And we tend to, one of the other things we do to make them very interesting, almost none of the couples are in the same field. So we mix, our food critic, public health couple with a historian and PE couple, with a judge and his wife who runs, I think, a women's health clinic. And I think those are the kinds of mixtures. It keeps it much more unpredictable, much more interesting. And I think, anyway, that would be my recommendation.
Everybody
Go have a good dinner party.
Organize a dinner party. On that note, please join me in thanking Zeke.
Thank you.
Thanks for listening to another episode of Leadership Rounds, where clinician executives share wisdom and insights on what it means to be an exceptional leader in healthcare. If you enjoyed today's discussion, please subscribe, comment, and share with your friends and fellow leaders in healthcare. Join us next time for another dose of leadership wisdom. Until then, I'm Dr. Reena Pande. Thanks for listening.